2L. If you'll note, the grading is, last year we had one exam, this year there will be two. And so there's one next Monday, and then there's one the following Monday, and then there is an SPBL in this one as well. There's no humanities to this section, but those two tests and the SPBL constitute the grade, with the SPBL being 10% and the two tests divided equally. Don Flynn is a PA, works at McBride, is going to give a lecture on radiology on Friday morning. He'll no doubt have tons of x-rays to show. There will be x-rays on the first exam, for sure, and maybe on the second exam as well, depending on how the lecturers go. There's Good Shepherd tomorrow morning, but there's no Good Shepherd next week. We're going to try to avoid Good Shepherd in weeks with SPBLs from now on out. So, unless you want to change. No? That's good? Okay. Because it's really unfair to the 6 that have that additional exercise. So that we'll just rotate, move those that would have gone next week, they're moved to the end. So you're not out experiences, just delayed. Any questions about this?
I have a question. You have next week with nothing on it. Is that, can you plan for that? To not
On
have-
Wednesday?
Yeah. Is that set?
Right now, there is nothing on it.
Okay.
I don't anticipate anything being on it. There was something on it, but Good Shepherd got moved, and the afternoon speaker had to move their date, so they've been rescheduled, and so it looks like Wednesday's free. And I'll try to keep it that way. The case study, I think it's this Friday afternoon. Is it this Friday? It's one of those exercises where Latassi and I are going to come down here. We're going to throw up some patients and discuss them like we've done before. It's optional. You don't have to attend, but it's there are some complicated patients, and there's some good physiology and some, bad physiology, if you will. Complex pharmacotherapeutics, so it's up to you whether or not you want to spend your Friday afternoon with us after the lecture. I think she lectures from 1 to 3, and then we're going to do the case notes. So this year, I did the musculoskeletal section last year, and there was one test, and I used what had been used at OU, because last year was the first year we gave it. And unfortunately, what we gave at OU was not good. And it was comprehensive, but it was too comprehensive. Nobody does that, ever. And so what I did was I took a little time, got rid of the extraneous stuff, and I sort of narrowed it down to a more simplified musculoskeletal exam. And that's what I'm going to present today. Now, leading up to the exam, the history side of things has not changed, of course. So what we're going to do is we're going to go over the PE of the axial skeleton, meaning just the vertebral column, and the appendicular skeleton, meaning your limbs. And then we're going to go over the test that should be performed as a matter of routine, and then I'm going to go through several special tests. I'm not going to go through all of the special tests because orthopedic surgeons and kinesiologists have come up with 50 billion tests to test every little muscle fiber in the body. I'm going to I've picked a few of them that are relevant to everyday practice and or common conditions, and we're going to go with those. Okay? And then we're going to do the normal and abnormal findings. Okay, so the HPI. When you look at the HPI, and someone coming in with a musculoskeletal complaint, you can divide it into different categories. One is joint pain. Ron's knee hurts.
It's his knee. It's just his knee. Musculoskeletal complaint would be, I have pain on movement. That, like tennis elbow, for example. Tennis elbow would be an example of that. It's not a joint, it's a tendon. Skeletal complaint meaning more of a global issue. Weakness, generalized weakness, disturbance of gait, as it says here. The limping child. The limping child, is it Legg-Calvé-Perthes disease? Is it slip femoral capitis epiphysis? You know, one of these things you're going to learn about in pediatrics. So is it a skeletal issue? And then injury, obviously, look at Professor Reggio. She'll be down here later on for you to do some testing on her knee. So that's to see a little pathology. And then back pain. Back pain is a category all by itself because it's very prevalent. It's prevalent in the aging population, it's prevalent in the working population, and it's very prevalent, almost ubiquitous, in the drug seeker population. So we're going to talk about that a little bit. Now, so when you get the HPI, in addition to the Big 8, these are the kind of things that you're asking related to the character or their description of the problem. So, and they differ a little bit. They differ a little bit, and you need to pay attention to it. Going up to joint complaint. One of the big things about the joint is range of motion. You need to assess, or you need to have them tell you what their limitation in their range of motion is, and then you need to assess that. We'll go over that later on. Anytime you're dealing with a joint, you want to, infection is always a possibility, so you need to make special note that the skin is not hot to touch, and that there is no erythema. I don't care if Ron sprained his, Ron is an ice dancer, maybe you didn't know that about him, and he sprained his ankle last night with his partner, and you know, it's clearly a sprained ankle, but you, in your description or your HPI, make sure you assess, is there any heat? Have you noticed any redness? And make sure you document that those things are absent in your physical exam findings. Okay? Very important. Do not miss a hot joint. All right. Efforts to treat down there. Oh, well, let me back up. Temporal factors, frequency, and better or worse as day progresses, because that will help you focus the differential diagnosis. Rheumatoid arthritis improves as the day progresses. Osteoarthritis worsens. Plantar fasciitis improves. A calcaneal heel spur worsens. So that will help you refine or begin to refine your differential, develop your differential, if you look at the temporal sequence. Plantar fasciitis is very painful in the morning. So is rheumatoid arthritis. Very painful in the morning. It's not until you stretch that fascia out or get the limbs or the joints loosened up do they feel better during the day. All right. Efforts to treat. You'd be surprised how many people come in and they have some joint complaint and have done absolutely nothing to address it. Not even a Motrin, not even a Tylenol. If I hurt somewhere, that's the first thing I would do. But you need to document whether or not they've done anything. The mnemonic is RICE, R-I-C-E. Rest, ice, compression, and elevation. If they haven't done that, that's probably, if it's just a joint sprain, for example, that's one thing that you're going to advise to do later on. And before we get too far into this, and there's a lot of controversy about this, is when you have a joint injury, do you use heat or do you use ice? And the way that I think about it, the way that I've learned it from various people, is that ice or cool for the first 24 hours, because that will decrease the blood flow to the joint and decrease the amount of inflammatory cells reaching the joint. But after 24 hours, what's there is there, and you need to improve the ability to get rid of it. So use heat after 24 hours and thereafter. And whenever you're using ice and heat, you don't want to put ice directly on the skin, and you don't want to put a heating pad on high and leave it on. You want to do it intermittent, 30 minutes on, 30 minutes off, and you want to do it low. Low ice, low heat. That's all you need. Okay? Okay. Moving down to injury. The character of injury, the sensation at the time of the injury, asking them, did you hear it or feel anything when it happened? It's not a definitive, I don't know what the specificity and sensitivity is, it's probably not very high, but if a person has a joint injury, for example, Ron with his ice dancing, did he hear it, did he feel a pop? That doesn't guarantee that there is a torn ligament, but it's something that you need to document, okay? And then back pain, get as much information related to the back pain as possible. The timing, is it worse in the morning, is it worse after you're working or standing all day? Did it start acutely, like if you were lifting something and all of a sudden acute back pain, versus every day I wake up with back pain, I live with back pain, I have chronic back pain. That's important to note. Also, is it one side or both sides, or is it midline? Do they have vertebral tenderness, or is it in the paraspinal musculature? A lot of people can, if we're moving something, I'm picking this up, and all of a sudden, oh my gosh, I pulled muscles in my back. They'll come in with paraspinal muscle spasm. You can feel the spasm in their back, but they do not have vertebral tenderness. It's in the paraspinal musculature. It's a strain. It's not a back issue. Versus somebody with degenerative joint disease of their back, a 70-year-old woman with osteoporosis, a lot of osteophytes, narrowing of the disc space, a lot of compression on the nerves. Their problem is pain over the vertebral column, not the paraspinal musculature. Okay? And before I get too far into it, just a word on muscle relaxers. Muscle relaxers, I may have said this to you before. There's ample data out there to show that muscle relaxers are effective if given within the first 10 days. But after 10 days, they're not effective. So there is no reason somebody should be on chronic muscle relaxers. Soma is a muscle relaxer. Do you know about Soma? Did we talk about Soma? Soma, once you ingest Soma, its first pass through the liver is converted to a drug called metropamate, which is a narcotic. So drug seekers, especially those with ill-defined chronic back pain, will always be looking for muscle relaxer, and it will always be Soma. They will never ask for Flexeril or one of the others. It will always be Soma because of the euphoric effect methylphenidate, in addition to the narcotic. Okay. Any questions about any of that? Okay. Moving on to past medical history with a musculoskeletal complaint. The trauma, a history of trauma to the joint, previous surgery or previous injury. That's, you need to know that. If Ron comes in with his ankle, I need to ask him, have you ever had surgery on that ankle, and have you had previous injuries with that ankle? If you sprained an ankle, you are more likely to do it again. If he has a, coming in because his partner in the ice dancing was throwing, his complaint today is a shoulder, but he had rotator cuff surgery 5 years ago, you need to note that. Okay? I bring up ice dancing because I went and talked to an ENT one time to see if he wanted to come play basketball with us. And he said no, because he was worried about, you know, spraining his ankle and stuff because he did ice dancing. It's like, are you freaking kidding me?
That's an elaborate lie.
Any questions about the past medical history? Skeletal problems, I'm serious, Abby. Skeletal problems here would be things like any type of inherited disorder that we'll bring up this afternoon, as a matter of fact, in pathophysiology of bone. Okay. Family history, there are certain things there that you need to ask or inquire about. The genetic disorders, osteogenesis imperfecta would be something, we're going to talk about that this afternoon as well. This is not part of the routine order of things, but if there is something that's leading you down the road of, wait a minute, this disorder may be more along the inherited line, then I would go that direction. If he came in with a shoulder injury, I'm not going to ask you about, do you have a history of osteogenesis imperfecta? No. Okay. Personal social history. You know, in Good Shepherd, most of those women that we see over there, if you ask them, are involved in house cleaning, working in a hotel, that type of activity. And they're always doing repetitive wiping of the surfaces and things like that. So if somebody's coming in with a hand complaint, for example, that carpal tunnel is on your differential, as you're talking with them, what motion do you do during the day? Well, I do this all day long. Or a roofer and hammering, or a bricklayer, you're going through the same thing all day long. The funny thing about, we were talking yesterday, Jessica Butler is getting ready to go to dental hygiene school. One of their common disabling disorders, I mean, it's almost ubiquitous in the profession, is bilateral carpal tunnel syndrome. More so than the dentist, because they're doing this, you know, they're doing the same motion day after day after day. I'd slit my throat if I had to be a dental hygienist. Anyway, that's another oh, you were a dentist. Yeah, I forgot you were a dentist. Yeah, exercise is another one. You know, there is a high-ranking administrator on this campus, and I'm not going to name him, but he complains all the time. I'd say he whines about his musculoskeletal complaints, yet he's a power lifter. There you go. Draw your own conclusions there. Your shoulder hurts? Maybe it was that 400 pounds you lifted. I don't know. So anyway, there you go. Any questions about that? No. A review of systems is very simple. Review of systems for musculoskeletal. You just run down through this. I tried to make some mnemonic for it, last night, and I never got this. John Smith was mad about, so anyway, I'll make your own mnemonic about it, okay? All right, so general principles of examination. These are the things you need to keep in mind. You need to document, you need to address these and document them every time. The first thing is symmetry. Just look at the joint unclosed or, with a gown on or a sheet on or something. You want to get a good look at the joint. Is it symmetrical to the other one? Is the back symmetric on one side versus the other? Put your hands on it. And like any palpation, you want to put your hands on them so you can assess temperature. And then as you assess the joint, the next one is range of motion. Make sure you have your hand on the joint so you can feel for crepitus or feel for effusion, any type of swelling within the joint, movement of water from one place to the next. All joints should be smooth. And the older you are, the more grinding you're going to feel in these joints. So make sure that you note in your documentation that there was no crepitus. And learn how to spell crepitus. It's not that difficult. Okay? I think that's spelled correct.
Not on mine.
C-R-E, oh. Whoa, wait, close your eyes, close your eyes. That's close. It's not T-I-S, that's what I mean. So, learn how to spell it. Do as I say, not as I do. And as you're going through the range of motion, make an assessment of stability. There are special tests for stability that I'll go over with certain joints, but you want to make sure that the joint is not lax. And if it is lax, you need to make sure you make a statement about its comparison to the other side. If you're doing a test on the knee, and on this person, you can move the knee this much, but it moves the same on the other side, it's normal for them. If this one moves this much and that one moves that much, then that is abnormal. All right. Range of motion is on this slide here. So when you describe range of motion, if it's full, in your mind, it's full, just note F-R-O-M, from, full range of motion. If there is a limitation, then describe the limitation. And for example, if I have a shoulder injury and I can do full range of motion, and the full range of motion is all those degrees there, and you assess degrees of a joint with this apparatus here called a goniometer. So if I get you to raise your arm all the way up, now hold it straight out, raise it all the way up. So if I look at the angle of him, then as far as abduction all the way up, it's 150 degrees. Okay? All joints have normal values. If you wind up in orthopedic surgery, you're going to know what those values are, but you don't. I don't need you to know them here. I need you to do get the joint in motion. If it appears full with respect to what you can do, that's good. Note it that way, full range of motion. Now I think some of the SPs, they do have limited range of motion of certain things. So if you don't have a goniometer, give it an estimation. Only able to abduct the shoulder to 45 degrees. Okay? All right. There's another thing about range of motion, and that is, there's a couple of things. One is, if you do it, if I get you to do that, that's active range of motion. He does it. If I do it, then that's passive range of motion. In certain injuries, having the patient do it is painful, but having you do it, where they're not contracting the muscles, you're looking more at the joint itself. It's not painful. You need to note there's pain on active range of motion, which tells you it's probably more tendinous, versus and no pain on passive range of motion. Or if there's pain on both, you need to be thinking more joint, bone on bone, or cartilage on cartilage, rather than or muscle. You see what I mean? The other thing is with and without resistance. So if you, there's a shoulder test we'll go over later on. If you take your arm and put it straight, like 45 degrees here, so it's not straight out and it's not straight abducted, it's about 45 degrees. If I have you raise it up against my hand, that's with resistance. Now, if he has a rotator cuff injury, what's the most commonly injured muscle in the rotator cuff? Yeah, that one. No. You're in the area. The what?
The one that's attached at the very end of the...
Yeah, it's the one up here, the the spinatus one on top of the supraspinatus. All right, that's a board question, I can guarantee you that. That's a board question. So the supraspinatus is a board question, and so is the damn anterior talofibular ligament for lateral sprains of the ankle, okay? Never forget those again. If I ask you 100 years from now, if I ask you again, you better tell me, oh, that's a supraspinatus. So if he puts his arm out like that, and he has a supraspinatus tear or injury, it's not gonna hurt him so much to do that. But if he does it against resistance, it'll light him up, okay? So document active, passive, with and without resistance. On every joint, always assess the vascular supply and the nervous and the innervation. Always note it. I don't know how many times people have been burned with nerve injuries or carpal tunnel, compartment syndrome, or some other musculoskeletal complaint where they did not document the innervation and the vascular supply. Find the radial pulse, find the ulnar pulse, find the DP and the PT pulses in the foot. Don't worry about the popliteal, but the foot pulses you need to document. Okay, if you're dealing with a lower extremity. If he comes in with a knee injury, I will document his pulses in his foot. Okay? Make sure you do. Strength, we talked about there in the neuro, is rated from 0 to 5, 5 being full strength, 0 being completely flaccid, and then subjective grading in between there. We'll talk about later on how to document that. You don't really need to, if you're doing a musculoskeletal exam, it would be very unusual for you to say the biceps is 5/5, the triceps is 4/5. That's a little bit too precise and subjective and probably wrong. So if you just say that the strength is intact, it's symmetric, and it's appropriate for development and age. I think I said this in neuro. It's appropriate for development. I wouldn't expect Julie's strength to be the same as Zane's strength. Right? So how are you gonna give her 5/5 if she can bench press only 150 pounds, he can bench press 152? So, you know, just, it's more subjective than that. Yeah. And then special test, we'll go over the special test. Okay. Now, so these are some areas or some times when you should put the musculoskeletal exam into play. Of course, with any limitation of ability. I can't, you know, a specific complaint. I can't do my job anymore. I'm having trouble getting out of bed in the morning. I can't do this or that. You need to do a musculoskeletal exam. Any pain, obviously. And with the aging population and with athletes, it's more of a screening issue. If you have a 60-year-old new patient in your practice, you need to do a screening musculoskeletal exam, because if that patient's in your practice 20 years, you want to be able to document the development of RA over those 20 years, or the effectiveness of your treatment in preventing the progression of RA over those 20 years. With athletes, you want to make sure in terms of the screening that they can perform their chosen sport. A sports pre-participation physical comes out of the OSSAA, Oklahoma Secondary School Athletic Association. OSSAA is a government, state government organization that monitors sports in junior high and high school. And they have a form on their website, the OSSAA website, the physical exam form. It has a history side and a physical side. You will be doing sports physicals a lot. I've done probably 50 of them in the past week. You know, this time of year, kids are going back to school. You have to have this form on file with the school before you can participate. Okay? And a large part of this form has to do with the musculoskeletal exam. So, and that's what we're going to go over today. The screening exam, that's what you do on a sports physical. Okay. Any concern with degenerative disease, the disc of the back, the disc of the knees, the disc of the TMJ, you need to do those tests. Muscular dystrophy, multiple sclerosis, and ALS, or in specific joint complaints. A lot of it has to do with athletics, like overuse, tennis elbow, golfer's elbow, and so on. Mechanical injury, sprains and strains, you need to make sure you know the difference between a sprain and a strain. A sprain is ligament, a strain is tendon or muscle. It says tendon there, but it's tendon/muscle. And then repetitive motion injuries, you see those. Amber Hicks is, you know, as young as she is, 10 years ago, with her typing, she wound up with carpal tunnel syndrome, pretty significant, and wound up with the surgery to repair it, even at her young age. So, and that cured her. Now, one of the things we hear from you guys about all the time is that, you know, I'm a student and I don't know the words to write when describing something. So I've given you a bunch of words, but here are a couple of others that when you're inspecting a joint and when you're palpating a joint, these are some words to use when you're presenting to your attendee. And they're very, they're chosen, and they're very, you should use these types of phrases, okay? Symmetrical is big. No atrophy, big. No gross deformity tells you a lot. Okay? Any questions? All right, so let's start with the physical exam. And what I'm going to do here is I'm going to go through these, the PowerPoint slides here. And then I've got another presentation, both of these are on D2L, that is more describes the exam, and then we'll do the exam, okay? So the axial skeleton, we'll start with that. When you're looking at the C-spine, you need to, again, inspect and palpate, again, range of motion of the C-spine. Strength is essentially range of motion against resistance. Pushing down on your hand, back on your hand, like that, okay? Deep tendon reflexes, anytime you're dealing with the spine, you need to make sure you include the neurologic exam. Deep tendon reflexes and sensation. Special testing for the axial of the C-spine. One of the things that comes into play, in addition to arthritis type problems, is thoracic outlet syndrome. Thoracic outlet syndrome can come from really 4 different varieties. There are 4 different varieties based on the anatomy up here. Thoracic outlet syndrome, if patients present with weakness or paresthesias in the upper extremities. Now, you know that things are dermatomally arranged, and it's very difficult to get a stocking-like paresthesias of the extremities, right? Carpal tunnel is very specific. Ulnar tunnel is very specific. You know, radial nerve injury, very specific. But stocking-like paresthesias, give me some couple of things that we call stocking paresthesias. What's that? Neuropathy caused by diabetes is probably the first thing. Spinal nerve compression, which is what we're going to talk about here, which is the thoracic outlet syndrome. There's one more big one. B12 deficiencies. B12 deficiencies cause stocking-like paresthesias. So in your, alcoholic population, there you go. So thoracic outlet is essentially something getting in the way of the brachial plexus or the vasculature as it exits the cervical area and into the upper extremity. That thing could be due to an extra rib. I think in anatomy I talked about a cervical rib. It could be due to hypothyroidism, where they're puffy, they're edematous, and you've got pressure, edema in this area. It could be due to excess musculature, hypertrophied muscles in this area. So the 4 areas, by the way, the 4 areas where you're dealing with this would be, I'll move your hair. By the way, the problem is back here, where the nerves are coming out. The problem is in the clavicle area here, because the brachial plexus, remember the brachial plexus, is in where the anterior and middle scalene divide. Remember the brachial plexus, the trunks were right there. So the scalene is another area where you could have a problem. So as they come out, they go right under the clavicle there. Remember you had to cut the middle third of the clavicle? They go right under the clavicle. So under the clavicle is another area where you have potential problems with thoracic outlet. And the other one is, remember the pectoralis minor comes up here and attaches to the coracoid process. So that's right here too. So those 4 areas, the neck, the scalenes, the clavicle and the pectoralis minor are areas where you could have neurovascular entrapment, producing thoracic outlet syndrome. And there are a bunch of special tests related to that. The Roos test, that's R-O-O''S, by the way. Roos test is basically, you have them sit here like this, put their arms up like this, and a little bit of extension of the shoulder. So you're stretching this area, and then have them do this for 3 minutes, or at least 90 seconds. All you gotta do is just have them do this. They don't have to do it fast or hard, just back and forth. So this will wind up reproducing the symptoms of the paresthesia in that position. Wright's test is what you do there is you're looking at the vasculature. We're going to take a. Did you guys notice this great big ring on her finger now? So this is your right hand. So this is not,
It's
never
my
mind.
birthstone.
It's her birthday. It's her birthday. She was born in August, so her birthday's tomorrow. So congratulations, Shelby. So what you want to do is you want to take and you want to feel. I'm not into. Do I need to get into?
Oh,
No, come on, come down here. Come down here.
thank you.
Okay. Just sit right here with your knees up. So Wright's test, what we're going to do is we're going to take her arm to 90 degrees here, her shoulder and her elbow, and we're going to feel for her radial pulse. And there's a radial pulse. The radial pulse is, the tendon right there is the flexor carpi radialis, so it's just beside that tendon, very easy to find. And now what we're going to do is we're going to extend it a little bit, extend her shoulder. Now I want you to put your head back. Now turn to look at me and take a deep breath. And take a deep breath and hold it. And what you're feeling for is that radial pulse. If you've got inflammation, edema, or cervical rib in this area, that pulse will go away. So that's Wright's test. There's another one called Adson's test, where you feel the pulse here. Got a nice pulse. We're going to come backwards like this, okay? Instead of our arm being up, it's down. Now turn your head back, turn and look at me, and take a deep breath and hold it. And you feel for that pulse to go away. She's got a strong pulse still. So, think about it. Oh, one more thing while we're here. Axial loading. So what you're doing there is, a positive test is an absence of the pulse. If you hold them there long enough, the symptoms will come back. I've seen a lot of, not a lot, I've seen thoracic outlet syndrome in people your age because they're sitting there, you're sitting there writing or typing. You're always in that position, and that position would decrease the arterial supply, and one woman in particular, her arm would go numb. Her right arm would go numb, or her left arm, one arm. And sure enough, she wound up having a cervical rib. Okay. Axial loading is, what we're going to do here is we're going to just put downward pressure on the cervical spine. So just put your hands like this on top of the head and push down. Now, this is not something you want to do to the average person. So what you can do to avoid liability is have them do it. Put your hands on top of your head, pull yourself into the table. Hard, hard, hard. So just straight down. So you're loading the spine. You can also do this with when you're looking at the lumbar region, but it really helps in the cervical region. Thank you. Okay? The thoracic spine, basically you're dealing with kyphosis or scoliosis. These physicals I did last week on the high school, I picked up 3 scoliosis in kids, and it was kind of funny. So I would say, has anybody ever told you you had some curvature to your spine? She said, no. I said, was your mom or dad here? She said, my mom's here. I said, go get your mom. So mom comes in, and I've got like 50 of these things to do. And so I said, here, I just want to show you. And I get the kid and I get her to bend down, and we'll do this here in a minute. And you can see a little scoliosis. I said, I just want you to see, there's a little scoliosis here. And she said, oh, I see that. And I stood up and I said, you don't need to do anything about it. We're just, it's there. I found it. So she said, oh, my husband's a spine surgeon. Okay. Anyway. It's like if you were to look at your teeth, your kids, and the kids had no teeth. And I was like, wait a minute, you missed that. The kids have no teeth. Lumbosacral spine, again, curvature, excess lordosis. Palpation, range of motion of big. DTR, neurovascular in the lower extremities is big. Most of the complaints you get related to the spine are going to be lumbosacral. And being able to weed out or differentiate what's true and what's not is going to be a big thing, especially if you wind up in primary care, emergency medicine, and so on. Okay? The special test related to the lumbosacral spine or rotation. So when we do the exam, it's basically you stabilize the pelvis and can they rotate and look at the wall behind them. All right. The other three, let me wait until we get that on the physical exam. Okay? Any questions about that? So let's take a little break and then we'll come back.